Now, ladies and gentlemen, once again, I present the 2019 Episteme Award recipient and our second plenary presenter, Dr. Stijn Blot.
Okay. This story starts in 1996. It is the year in which the first randomized controlled trial is published that compared chlorhexidine oral care versus standard oral care in the prevention of pneumonia in cardiac surgery patients. To understand why this was done, I have to take you through the pathogenic mechanism of intubation-related pneumonia or ventilator-associated pneumonia. So what you see here is a patient that is intubated. So you bring the endotracheal tube into the trachea, and once it is in place, the cuff is inflated. The inflated cuff allows you two things. First of all, it allows you to ventilate the patient with positive pressure, okay? But secondly, and more important for what I'm going to say today, is that an inflated cuff seals the extraluminal airway and thereby avoids aspiration of subglottic secretions to go into the deeper airways. Okay, that's an important thing in order to avoid pneumonia, but the problem is the seal does not work perfect. And why is that? Well, when you look at the picture, you look at the cuff, an inflated cuff into a trachea does not look like that at all, no. It's full of folds when it is inflated into a narrow space like the trachea. And along these folds, they have the formation of what we call microchannels. And along these microchannels, microaspiration of subglottic secretions might occur. Now you can understand that these secretions are coming from the oral cavity. It's full of bacteria, okay? So the idea behind giving oral care to an intubated patient with an antiseptic is not to block the microaspiration, that's the main problem, but you can't do anything about it, but is to lower the microbial load within these secretions that sneak into the lower airways and might trigger pneumonia once they are there. That's the idea. So we hope that with some kind of decontaminating the oral cavity, that we might have a reduced risk for pneumonia in these very vulnerable patients. Okay. This is the study, DeRiso Chest 1996. Randomized controlled trial, double-blind, placebo-controlled. It's on the top of the study designs that we derive evidence from. Okay, it's the top. Intervention, chlorhexidine oral care with a solution of 0.12%. In cardiac surgery patients, not unimportant. You will understand later on. DeRiso and colleagues looked at various outcomes, but for us today, we focus on lower respiratory tract, pneumonia, and mortality. Good. These are the data. So you see from the table that in the chlorhexidine oral care group, pneumonia was 1.6%, placebo group 5%. The mortality rates in both groups, respectively 1.2 and 5.6. The column at the right indicates whether or not this is statistically significant. Now, it took me a while, but I had the courage just to give you 2 slides only about how to interpret a risk ratio or an odds ratio and 95% confidence intervals, just because I think that at least some of you might not on a daily basis be busy with p-values and odds ratios and things like that. Okay, this is my job, this is what I do, but fortunately they're not all like me. So, statistical intermezzo. The basic principle of a risk ratio, whether it is relative risk or odds ratio, is a chance. What is the chance of experiencing pneumonia when you are exposed to chlorhexidine oral care? Okay. When your risk ratio is 1, this means that your chance is equal because you have 1 time more the chance of having pneumonia when exposed to chlorhexidine oral care. So logically, when your risk is greater than 1, you will have an increased risk of meeting the outcome variable. Okay. The other way around, when you have a risk ratio which is lower than 1, you have a decreased risk. But is it statistically significant? Therefore, we have to look at what we call confidence intervals, 95% confidence intervals. And these borders define with 95% certainty where the effect truly is. There are 4 possible situations. The first is already on the slide. Like, I have an example here of a risk ratio, odds ratio of 2.8. And the confidence interval is 1.5 to 4.3. Is the relationship between chlorhexidine oral care and mortality really 2.8? I don't know. But what we do know is that the true effect is somewhere between 1.5 and 4.3 with 95% certainty. And then we say, well, the point at which the chance is equal, 1, is outside this confidence interval. In other words, the confidence interval takes distance from the point where there is no difference at all. Takes distance from where there is no difference at all. So, and then we say it's statistically significant. Second situation, you have an increased risk, but you can see now that the confidence interval includes 1. So I repeat my sentence. With 95% certainty, we can say that the true effect is somewhere between 0.8 and 5.2. Which means that as well there might be a chance that you have a decreased risk, somewhere between 0.8 and 1. And then we say it's not statistically significant. And the other way around, when you have a decreased risk, this is statistically significant. This is not statistically significant. It's all about the central point, 1. Let's go back to the DeRiso study. You can see that for what concerns pneumonia risk, the risk ratio is 0.35. But it is not statistically significant. It is reduced, but it's not statistically significant. But who cares? There is a significant reduction in the risk of mortality. Hallelujah. Okay, that's great. No worries. And so we see that in the years to come, many other randomized controlled trials have been conducted in various ICU populations. Again, cardiac surgery, but mixed ICUs, trauma patients, whatever. And to complicate things a little bit, researchers used different concentrations of the oral care solution. And they looked at different outcomes: respiratory tract infection in general, ventilator-associated pneumonia, or the more broader approach of nosocomial pneumonia. All things making interpreting difficult. And when we look at the results of all these studies, mostly there was a reduction in the risk of pneumonia. But mostly it was not statistically significant. 2011. What do researchers do when you have a bunch of randomized controlled trials that are not really conclusive? They make a meta-analysis. This is Sonia Leboy is my ever best PhD student. She's awesome. She conducted a meta-analysis looking at oral care with an antiseptic in the prevention of ventilator-associated pneumonia. 14 studies. 12 with chlorhexidine, okay? Adding up about 2,300 patients. All right. This is the forest plot. And you can see at the right bottom corner that when you pull all the results, that there is a significant reduction in the risk of pneumonia. Okay, that seems good. But please realize that we have pooled here studies in different populations with different oral care solutions, concentrations, etc., etc. So when we did some sensitivity analysis, things were not that great. And we wrote it in the paper, like, be careful. Because when we look at the different concentrations, we only see a significant reduction in the risk of pneumonia with a 2% solution, which is, of note, not even commercially available. Most studies work with 0.12 of 0.2. When you look at the different patient populations, there's only a benefit in cardiac surgery patients. Strange, huh? No, that's not so strange. Because in cardiac surgery patients, mostly pneumonia occur very early in the intubation time. It's called early onset ventilator-associated pneumonia. And early onset ventilator-associated pneumonia are mostly caused by gram-positive bacteria. And chlorhexidine is much more active against gram-positives than against gram-negatives that cause more pneumonia in mixed ICUs and in medical ICUs. That's the reason. Nevertheless, despite our overt warnings like do not exaggerate with overinterpreting these data, we have seen that this practice, chlorhexidine oral care, has been promoted excessively. And strangely enough, not only in cardiac surgery patients, but to all patients who are mechanically ventilated. And in clinical practice, just for convenience sake, also in patients who are not ventilated in the ICU. Like one size fits all. There was some kind of very strong belief that these practices, recommended by some very powerful institutions, CDC, IDSA, there was some belief that, well, there might be no proven benefit, but there will be no harm at all. So let's just do this for everyone in the ICU. No worries. Okay. Things start to change in 2014. Say hello to Michael Klompes. He's an American investigator with a very strong focus on patient safety, especially in ventilator-associated events. He did also a meta-analysis of randomized controlled trials of chlorhexidine oral care, but he broadened the scope from ventilator-associated pneumonia to nosocomial pneumonia. So he had more studies to pool. And he did not only look at pneumonia risk, but also at mortality risk. Makes sense. If you have less pneumonia, you might have perhaps less risk of death as well. The pneumonia data confirmed what we found before. You only have benefit in the heart surgery patients. In non-cardiac surgery, a reduction, but not statistically significant. But now it comes. When he looked at the mortality risk, he noticed a trend towards increased risk of death among all the studies pooled that reported mortality, 12 RCTs. Now I know that some people are saying, it's not statistically significant. 0.99. Okay. It's not statistically significant, but it does not comfort me at all. This is really very close of being statistically significant. So if you have a little bit of common sense, this must give you a very strange feeling. Something might be wrong here, really. Interestingly, when he looked at cardiac surgery and non-cardiac surgery patients, he noticed that the increased risk of mortality, or the trend towards, I should say, because it's not statistically significant, was completely due to the observations in the non-cardiac surgery group. Take note, this is exactly the group of patients for which there was no evidence of a risk reduction in pneumonia. Okay? Only 3 months later, Richard Price, British Medical Journal. That's not such a bad journal either, okay? Network intervention, network meta-analysis of interventions, SDD, selective digestive decontamination, selective oral decontamination, and chlorhexidine oral care. We are only focusing on the chlorhexidine oral care. Different with the previous meta-analysis is that Richard Price and colleagues only selected general ICUs. They excluded every specialized ICU, the cardiac surgery, the liver transplants, the neurotrauma, and things like that. Only mixed general ICUs. And they looked only at mortality. In the red square, odds ratio 1.25 and statistically significant increased risk of death. Now, this gives you a very strange feeling, no? I invite you to look a little bit in more detail to these data, and I hope the slide is big enough for you. Of these 11 studies that are in this meta-analysis, there were only 3 that indicated a direction of reduced risk of death. Not statistically significant, by far not statistically significant. But all the others were pointing out in the direction of there might be an increased risk of death. Not statistically significant, except for one. It's a study by Cindy Monroe and group, American Journal of Critical Care, 2009. And the strange thing is, this observation was actually not even mentioned in the results. It was somewhere hidden in tables, and you have to calculate all different figures together in order to find this result. And it was not mentioned in the discussion also. So what happened? I don't know. Perhaps they simply did not notice it. It's only human. Or they thought like, this is a complete coincidental finding. And I mean no offense, really, I mean no offense to this team. This is a great nursing team of researchers. And it's very easy to criticize other men's work. Very easy, okay? What I want to say, this is a shared responsibility we have here. Because this paper was also sent to reviewers. It was approved by an editorial board. And once it was published, I did not notice it. It's also my responsibility. I'm a researcher. This is my topic. I should have noticed it. And I didn't. If I did, I should have wrote a letter to the editor, like, this deserves a comment. What's your opinion about this? And in that case, we would have been able to start this discussion in 2009. No, we had to wait for 5 years longer for the data of Michael Klompas. But to be honest, I'm afraid that if I should have seen it, that I would just have said like, coincidental finding. Bad luck. Yeah, I'm sorry. 2016, another study by Michael Klompas, cohort study, retrospective, looking at the individual effect of all different practices that are in a ventilator bundle. And Michael Klompas found that in patients who were ventilated for more than 3 days and received chlorhexidine oral care, that they had a greater risk of death, of dying on the ventilator, than patients who did not receive chlorhexidine oral care. A study of 5,000 patients. 2017, important. for the first time, there is a guideline published from several very powerful scientific organizations on the management of healthcare-associated pneumonia. And the experts are saying, like, for what concerns chlorhexidine oral care in the prevention of pneumonia, we give no recommendation. That's already very strong. This has been promoted by CDC, by IDSI, by the ATS, So they're not really recommending against its use, just saying no recommendation. And they're clearly said, like, we do not know what it is, but there might be something wrong with this product. And as long as we have no more clarity, we give no recommendation. We are getting close. 2018. I wondered, like, okay, this is all about the ICU, but oral care is also provided outside the ICU. It's used for other things than prevention of pneumonia. It's used in oral pathology, gingivitis, periodontitis. It sometimes is used as a standard of care in patients who cannot care for their oral hygiene themselves. I would not really recommend that. Why would you use an antiseptic for that if there is no oral pathology? But I know that this is done by some nurses. Okay. So you have also a broad spectrum of patient populations. ICU, geriatrics, hematology, whatever. It's used everywhere. So what I did was, I undertook a systematic literature review, looking for RCTs, comparing chlorhexidine oral care with standard oral care, outside the ICU, and trials that, as a primary or probably a secondary outcome, define mortality. It was not published because there are none of such studies. There are simply none. And this is the reason why in Ghent, with Mieke de Schepper as data scientist, we conducted this study. It's a hospital-wide, retrospective, observational cohort to assess the effect of chlorhexidine oral care on hospital mortality, hospital-wide study. Ghent University Hospital, 3 years, good for 82,000 patients. 11,000 of these patients were during their hospital stay exposed to chlorhexidine oral care. And this group, 11,000, we split into low-level exposure and high-level exposure on the threshold of a cumulative dose of 300 milligrams. For all clarity, 300 milligrams is what is in a single bottle of 250 ml oral care solution, 0.12%, what is used in our hospital. And it should cover like 5 to 6 days in a single patient. Good. It's a cohort study, so it's very important to adjust for risk factors for mortality, because you can imagine that a patient who receives chlorhexidine oral care might be more sick than the average patient not receiving chlorhexidine oral care. So what did we have in the balance? Age, sex. Was it following an emergency admission? Was it medical or surgical admission? We had all diagnostic categories following the ICD classification to adjust for. And very important also is that we were able to stratify our patient population according to a risk of mortality score according to the EPR-DRG classification. This is a very strong post hoc classification, so it is calculated when the patient is discharged, post hoc. And it takes everything into account. Age, of course, sex, emergency, what was the patient admitted for, how many and for what were their surgical procedures, what were the complications, and within all this, also interactions. So this classification makes a distinction between patients with minor, moderate, major, or an extreme risk of death. Let's go through the univariate, so unadjusted, rates of mortality. So at the right, you see patients without chlorhexidine oral care. Low, high exposure. Mortality rates, 1%, 11%, 18%. Okay. We stratified this. It's still univariate, so unadjusted for other severity of disease and things like that. And you can see that for the risk categories, minor, moderate, major, there was always a significant increased risk of death in the patients exposed to chlorhexidine. But interestingly, when you look at the patients with an extreme risk of death, 2,470 patients, the observed mortality was equal, around 43%. But this is, of course, all unadjusted. What really counts is the logistic regression. And we found that compared with patients who are not exposed to chlorhexidine oral care, those exposed either low or high had an increased risk of death, an odds ratio of 2.6, with extremely narrow confidence intervals, indicating that mortality risk is at least doubled after adjusting for everything that might have something to do with mortality. Very, very strong statistical data. Now, based on this regression model, Mieke de Schepper was able to calculate the adjusted number needed to harm. So how many patients do you need to expose to chlorhexidine oral care in order to see one additional death, one additional fatal case? 47. And most people have something like, what? Only 47? Yeah, only 47. But as a researcher, to me, now it becomes clear why it took so many years to come to this result. It's clear that when you need almost 50 patients to see one additional fatal case, that it is clear why this phenomenon has been staying under the radar for so long. How on earth are you going to prove an increased risk of mortality in a trial comparing 2 times 100 patients if you need 50 patients on average to demonstrate one additional death? There is no way you can do that. We needed these large meta-analyses. We needed these large cohort studies. Okay, let's look at several risk groups. And when we look at the patients with the minor or moderate risk of mortality, you can see that the association with risk of mortality following exposure to chlorhexidine was very high, odds ratio of 5. In patients with a major risk of death, 2.3 or 3.1, also statistically significant. And strangely enough, when we look at those exposed in the extreme level, the very sick patients, the relationship was not there. Okay, I have an explanation for that, but I don't have the time. Ask me later. I'm here until Wednesday. When we looked at different subgroups within this cohort, the cardiothoracic surgery, no risk of mortality that is increased. In the non-ICU group, again, very strong increased risk of death. In the non-ventilated ICU patients, no increased risk of death. But now it becomes interesting. This practice was originally promoted for ventilated ICU patients. So we were able to split this group in long-term ventilated patients and short-term ventilated patients. In the long-term ventilated patients, more than 96 hours, there was a slight increase in the risk of mortality, but it was not statistically significant. No worries. But then, in the ICU patients that were short-term ventilated, there was a survival benefit for those exposed to chlorhexidine oral care. This is not happening to me. What am I going to write in this article? But after some days, it's getting all clear to me. Like, this is a marvelous example of what we call survival bias. This is a study in a single hospital, 4 intensive care units. In all these units, there is a protocol. A ventilated patient must receive chlorhexidine oral care. So why is it that about 10–11% of these patients did not receive chlorhexidine oral care? I think that a lot of these patients died before the first oral care provision. And of course, this creates a survival bias for the patients who survived the acute phase and were exposed to chlorhexidine later on. Unfortunately, I did not have the data in the database to adjust for this. And I begged the editor, like, I don't want to write this in my article because people will use it differently, they will use it in the wrong way. So it is in the discussion where I explain this. But honestly, I do not believe anything that in this kind of patients, it will add survival benefit. At most, there will be no effect. Probably there will be no effect, okay? So how to interpret? It's a very large study. We had no missing data, 82,000 patients. Strong relationship. Relationship particularly strong in the patients who are supposed to just walk in the hospital and walk back out. Those without a strong risk profile at all. The biggest problem of this study is that we have no clue what might be the pathogenic mechanism behind this. And as a researcher, believe me, this puts you in a very weak position when you come up with controversial data, okay? Believe me, I have had very tough discussions with the reviewers and outside, okay? Of course this study has limitations. Of course, it's observational. We are missing detailed length of stay data. We only had 1 oral care solution, but it was rather low, and yet we saw an increased mortality risk, so, okay. So tomorrow, you are going back to work. You are standing before your patient with your bottle of chlorhexidine oral care solution. Do I like him? Oh, this is so inappropriate. Do you think that this patient might benefit from oral care with chlorhexidine? If you ask me. If you do not work in a cardiac surgery ICU, forget about it, but you're free, okay? If you think yes, please, I invite you to balance the risk with the presumed risk of mortality. And irrespective of this, you know, there are other solutions on the market as well. We have no detailed safety data on that, but at least for some other products, they are still not compromised. They have the benefit of the doubt. Chlorhexidine, okay. So my take-home message for this particular study is that these data should, you might question them, but they should at least incite some reconsideration of this practice, okay? 7 minutes to go. Let's become a little bit more philosophical now. So this study was published in Intensive Care Medicine, and it was accompanied by 2 editorials. And one editorial was saying, okay, now we know enough. Stop this. It's from Michael Klompas. And the other one was saying, well, it's only single center, it's retrospective, insufficient data. Let's just go on. I tried to be open-minded, but okay. And I started to wonder, like, do we deal with research results in a different way, especially when we do not understand the pathogenic mechanism behind it? Do we deal with them differently when the message is positive than when the message is negative? Like we have seen in this story that I told you, like we had only limited evidence that chlorhexidine oral care might reduce pneumonia risk. Excessive promotion in cardiac surgery, outside cardiac surgery, ventilated, not ventilated, everyone. And then you see there might be an increased mortality, and suddenly, we have lots of methodological concerns. Like, it's only single center, you know, we have been doing this for years without seeing any problems. That's one of the things I hear a lot. So do we react differently according to studies with a positive versus a negative message? Especially when the negative message points out something that we have been doing for years and we don't feel very comfortable about it, that we found something that is really harmful, and we've been doing this for, oh my God, for so many patients. Like, we are scientists. We should look at the data in a very objective way. The data, and only the data, will guide us in our decision making. No. I'm afraid not. And I'm afraid there are a lot of stories like this in literature and daily practice. I just bring to you this study. It has nothing to do with chlorhexidine oral care. It's about transfusion policy. Transfusion. Large study from the Netherlands, 31,000 patients. And they looked at, is there a link with mortality when patients receive transfusion from a male donor or a female donor, and whether this female donor ever has been pregnant, yes or no. Interesting. Now I can tell you, when you get blood from a male donor, there is no problem at all. It is like that, okay? Female recipients. When a woman gets blood from another woman that has never been pregnant, there is no link with mortality. When a woman gets blood from a donor that is also female but has ever been pregnant, no risk of death. Okay, so that's fine. Male recipients. When men get blood from female donors, never pregnant female donor, you see that there is an increase in mortality. It's not statistically significant, but it's again very, very, very close, 0.99 confidence interval. Very close. And when the female donor ever has been pregnant, there is a significant risk of death for the male acceptor of the transfusion. Now, this is not about transfusion-related reactions that occur in the acute phase. No, this is mortality at 3 years. Scary, huh? Well, it is for me, okay? So, may I ask you, is there anyone in here that can say, we changed our transfusion policy based on that study in our hospital? I will not ask you anything, just yell. Okay, I was already afraid for that. So what is wrong with us? It should not be so difficult to change your transfusion policy. When I was born, men were walking on the moon. This is just blood, male to male, female to female. And we do not understand what's going on here. Okay. Back to the chlorhexidine study. This is my last slide. What we have been seeing here is that there was only limited evidence of reduced pneumonia risk only in cardiac surgery patients. But the practice has been applied to many other patient populations, okay, without any evidence. We saw the initial neglect of a randomized controlled trial indicating an increased risk because we thought, yeah, this will be an incidental finding. And then, year by year, we saw that the evidence is accumulating that chlorhexidine oral care might be harmful. Point 5 on my slide. When you have the body of evidence indicating that this practice might reduce the risk of pneumonia, and you balance it with the evidence that it might increase mortality, I would say the body of evidence that it increases mortality is higher, but I'm biased. So just let's agree that it is the same. It's the same. Your choice to make. Are you willing to take the risk of a presumed benefit in risk of pneumonia, and that is linked with an increased risk of death? Well, that's an easy choice for me, but you don't have to listen to me, of course. It's an easy choice for me. So the message for today is, please be open-minded when you look at data. Beware of over-interpreting what we like as the message in our articles, okay? And when the result is indeed very positive, are there any safety data? And if they are lacking, please beware of extrapolating this practice to populations for which there is no evidence. I can conclude my talk, but not before I express my gratitude to Sigma Nursing's Award Committee for granting me the great honor of the Episteme Award. Thank you very much.
Now, thank you, Dr. Stijn Blot, for your work. Is inspiration to us all, and thank you for explaining the complex methodological issues that we are confronted with in research, and how important high-quality RCTs or high-quality methodological studies are for our profession. Thank you.
Thank you so much.
Now, and special thanks to Baxter International Foundation for making this prestigious Nursing Research Award possible since 1989. Now, this concludes the second plenary session. I hope you find the rest of the day eventful and inspiring and enjoy the conference. Thank you.